Learn about antimicrobial stewardship testing in the era of multi-drug resistant organisms. We will be learning about relevance of sensitive testing in managing infections, then timelines for reporting, manual versus automated options for sensitive testing, and how to interpret AST results. The antimicrobial stewardship testing help us to detect the possible drug resistance in common pathogens, susceptibility to choose an empirical antimicrobial agent for particular infections. Most common clinical significant infections observed in ICU are catheter-related bloodstream infection, ventilator-associated pneumonia, catheter-associated urinary tract infections. So, sample collection, storage, and transport is a critical step in sensitivity testing. Regarding collection, the blood samples will be inoculated immediately onto the blood culture media to prevent clotting in the syringe. In case of CSF, if Neisseria meningitidis is suspected to be the cause of illness and a delay of several hours is anticipated, then incubate the CSF at 35 degrees Celsius in a 5% carbon dioxide atmosphere. This may increase the chances of yield. For blood storage, it should not be refrigerated. Similarly, CSF should not be refrigerated. Both the samples, blood as well as CSF, are the precious samples and they should be reached the laboratory within 12 to 18 hours for subculture. As soon as the CSF has been collected, it should be transported immediately to microbiology laboratory. The blood samples should be processed in the laboratory within 2 hours of collection and CSF within 1 hour of collection. For blood, a paired bottles are required. That is a pair of aerobic and anaerobic bottle from left hand and a pair of aerobic and anaerobic bottle from another hand. This increases the yield of isolation of the pathogens from the sample. To transport all the specimens as soon as possible, specimen must reach the lab in sterile, leak-proof containers and sealed plastic bags. If the specimen cannot be transported immediately to the lab, then the urine, X-ray, food, throat swab, ear and bacterial and for culture and blood can be refrigerated at 4 degrees Celsius, while blood culture bottles and CSF can be left at room temperature. Once the collected and samples are sent to the laboratory for further evaluation, timelines for result will depend on following steps. One is standard inoculation preparation, then broad microdosing, then inoculation and incubation, and reading the results. Standard inoculation preparation, where well-defined colonies are selected from the culture plates, which develops after the incubation of 18 to 24 hours. Then the dilution of the bacterial suspension is made for MIC, and it should occur within 15 minutes after making the standard inoculum. Inoculation of the sample should be done on suitable growth medium and should be incubated for 18 to 24 hours. Measuring the zone of inhibition or the MIC should be done as soon as the zones of inhibitions are developed and the 18 to 24 hours of incubation is over. Interpretation of the AST results we'll be seeing in the next set of slides. In automated systems, this consists of automated inoculation of the MIC panels followed by computerized assisted incubation with reading, interpretation, and reporting functions that do not require any manual intervention. In semi-automated system, it consists of manual as well as automated. Each panel is loaded into an automated reader and computer-assisted reading and interpretive reading of MIC is performed. In manual AST, the panels are antibiotic discs are incubated manually, and it is the zones of clearing are read visually by lab personnel, and the results are either entered by hand or manually into the computer for interpretation and reporting. What are the advantages and disadvantages of manual testing? The advantage is that it has an intrinsic flexibility by being able to test the drugs the laboratory chooses. This method is best suited for a situation in which MIC for 1 or 2 doses is needed. E-test results have correlated well with the MIC generated by automated systems. However, the issue with the antimicrobial testing in case of manual testing is that there are some systematic biases towards higher or lower MICs. It can become expensive if more than few drugs are tested. In this division, the advantage is it is a simple, practical, and well-standardized method. The results can be easily interpreted by all clinicians. However, it is less costly, but results are very qualitative. Accurate MICs can't be determined. Not all the fastest bacteria can be accurately tested by this method. The advantages of automated machines is that the use of instrumentation can standardize the readings of endpoints, produce susceptible testing results in shorter period than in manual readings, and has a better data management. But the disadvantage is that it is expensive, requires space for instrumentation, and unable to detect some resistant phenotypes like VAN A, B, C, and others. We have automated systems like Phoenix and Whitetech and Bactech and Bacterial for blood cultures. Then in case of hospital infection, any delay in the antibiotic treatment will worsen the prognosis and may also increase the mortality rate. In manually sensory testing, sample collection and transport should take place within by 30 minutes. Inoculation and incubation will take about 24 to 48 hours, and report it takes about 24 hours. So, and the therapeutic decision takes about after 2 to 3 days of this process. While in automatic sensory testing, the sample collection takes about 30 minutes, incubation and report takes about 2.5 to 16 hours. The therapeutic decision is quicker 1 or 2 days earlier as compared to manual testings. So with the use of automated method, one can get the report on the same working date that can help the clinicians to start early treatment. Optimal interpretation of MICs requires knowledge of the pharmacokinetics of the drug in humans and information on the likely success of the particular drug in eradicating bacteria at various body sites. Common terminology used are susceptible, intermediate, and resistant. Susceptible means that the patient organism should respond to the antibiotics used in normal dosage recommended. Resistant means that the organism will not be inhibited by the concentration of antibiotic in the dosage recommended. Intermediate, that the clinical response is likely to be less than the susceptible strain. And what are MICs? MICs is the minimal concentration of antibiotics needed to inhibit the growth of the isolate. Breakpoints are the discriminant concentration. The discrimination concentration used in for MICs used in the interpretation of this MICs as sensitive, intermediate, or resistant. So these breakpoints are given by FDA, CLSI, and UCAST, which are the international bodies which determine the breakpoints. How to interpret this diffusion method? The results of this diffusion tests are qualitative. In that we have categories like sensitivity, intermediate, resistance. It is derived from the test rather than an MIC. The diameter of the zone, the clear zones of inhibition is relates to the susceptibility of isolate and to the diffusion rate of the drug into the agar medium. No zone around the disc means it is the antibiotic is resistant. If there is clear zone of clearing agar and the antibiotic disc, there means it is a sensitive either or as intermediate based on the breakpoints. Zone diameters of each drug are interpreted using the CLSI guidelines or UCAS guidelines or FDA guidelines, and the zone of clearing is interpreted either as sensitive, intermediate, or resistant. Similarly, for this, we have MICs2, which we refer to the CLSI guidelines and UCAS guidelines to interpret the MICs either as sensitive, susceptible, dose dependent, intermediate, or resistant. Genotypic sensitive testings are effective methods that eliminate tedious bacterial cultures, long incubation, chances of contamination, and spreading of deadly infections. PCR, DNA microarray, and DNA chips, and loop-mediated isothermal amplification are some of the genotypic methods for the detection of antibiotic resistance. Rapid detection of resistance within few hours helps in making decisions to use more specific antimicrobial agents rather than broad spectrum agent. Take an example, say XYZ patient, a 49-year-old. The patient was admitted to a nursing home with complaints of fever, chills, and coughing. Patient was put on coamiciclo. The patient started complaining of blood in mucus, shortness of breath. He is diagnosed as ET secretions is corrected. ET secretions then sent to the microbiology lab for culture. It yielded Klebsiella pneumonia. And the Klebsiella pneumonia was sensitive to only colistin, as you can see from this report. Now, which drug to test? Lab reports indicate that the patient is infected with Klebsiella pneumonia, which is resistant to various antibiotics, and very sensitive to colistin and susceptible to certain albactam. Rise in the carbaphan. What are the current issues with the colistin? Rise in the carbaphan resistance leads to increased uses of colistin, which usually increases the colistin resistance. Handling of the colistin challenges involve both laboratory as well as therapeutic management. Therapeutic challenges with colistin such as nephrotoxicity, neurotoxicity, vasculotoxicity, promotion of resistance is an issue with colistin. Colistin is a very heavy molecule and diffuses very poorly into the lung parenchyma, as well as there are challenges with regarding testing. So the colistin has poor penetration into lung parenchyma. Hence, it won't be used for management of the pneumonia. CLS has removed the susceptible breakpoint for colistin also against Pseudomonas acinetobacter and Enterobacteriosus. There are numerous uses related to colistin. So the only option left behind with us is the ceftazidime ivermectin for this particular case. Ivermectin is a potent novel diazebicyclococtanol beta-lactam inhibitor with inhibitor activity against classes A, C, and some class D beta-lactam. When used in combination with ceftazidime, ivermectin restores the activity of ceftazidime against gram-negative organisms, producing carbapanones, as well as many co-cardiac ESBLs. Taking the consideration of issues related to colistin in ICU setting and positivity of ivermectin ceftazidime, this patient was started on ceftazidime ivermectin therapy. So that's how we to this case study we understand how the antibiotics needs to be selected based on pharmacodynamics and how to interpret the sensory testings. Thank you.